My name is Peter Inkpen, and this is a learning ultrasound educational series. This may become a podcast, but it may not. You can check my YouTube channel for some ultrasound educational material as well. Today I'm joined by Dr. Mohammed Badie, who is a rheumatologist, and we're going to talk about Doppler imaging. Mo, before we start, can you give us a brief introduction to who you are?
Sure. Okay. Hi, I'm Dr. Mohammed Badie. I'm a rheumatologist practicing in Vancouver, BC, part of the Division of Rheumatology at UBC. And my area of interest in rheumatology has been use of point-of-care ultrasound. And I'm a U.S. Sonar Fellow and a junior faculty member as well.
And a great dresser. You can't forget that.
And Ellie's been giving me haircuts. So.
Yeah, actually, I got my haircut today. Allison cut my hair for the first time today. I think it's going to be this trend. Of course, now she is just like, well, I could do this all the time. I don't know. We'll see. I kind of like just going and getting my hair cut.
Life will not be the same after this.
Well, there's a big difference between like sitting in a chair and getting your hair buzzed by your wife while your 4-year-old just kind of stares at you and then tries to distract you. It's just not as relaxing, Anyway, so I will call you Mo, and but Dr. Bardi is an amazing rheumatologist, and we've worked together side by side. I've learned a lot from him. He's also a great clinician and very skilled with ultrasound, and both of us are trying to improve our ultrasound practice as well. So today I got Mo here, and I'd like to talk a little bit about just Doppler imaging. I think that it's one of the things that gets missed at a lot of the non-rheumatology courses, and is really underutilized as a skill in MSK medicine and neuromuscular medicine and that kind of thing. What do you think about that, Mo?
That sounds great.
Yeah. Do you see much talk about Doppler imaging and that in the rheumatology conferences and that these days?
Yeah, so first I just want to say, Peter, thanks for having me here. It's always fun to be able to reflect on the things that kind of use on a day-to-day basis. But I'd say that from the moment I started my training with ultrasound, especially going through US Sonar, there's a huge emphasis not just on Doppler, but understanding some of the physics behind it and what it is we're actually able to extrapolate. Mm-hmm. I think as much as the grayscale images that we see to look at different structures from bursas and tendons and, to be able to appreciate those structures in nerve tissue, Doppler for rheumatologists who do ultrasound is huge. It's so critical because it's what we use to look at active disease versus an infusion, right? And there's now agreed upon international criteria by which how we grade not just grayscale changes from grade 0 to 3, but also Doppler changes that we see. And these actually carry therapeutic implications. Mm-hmm. So whenever I see a patient and I scan them, I do report the changes on the Doppler. And any rheumatology ultrasound course that you go to is never complete without a quick review or primer on Doppler settings.
Yeah. So tell me, just walk me through the optimization of power Doppler imaging.
Yeah, for sure. So, yeah, go ahead.
Because I think if we, like what I've been doing with my learners is trying to simplify it and just using power Doppler as a primary imaging. Forget about the direction of flow and velocity and these kind of things, and just looking at low flow structures first.
Yeah, I'd say just like when we think of grayscale, if we kind of go through some of the same settings first to kind of touch on what are some of the parallels that are the same. One, when you turn on your Doppler box, like where you position your box is going to be important. We know that the wider you make your box, so sometimes people wonder, like, why don't I just put the Doppler box to fill up the whole screen? Mm-hmm. And if you do that, you're going to lose sensitivity in your Doppler window, right? So trying to narrow the width to the area that you're precisely interested in will help improve the sensitivity of your Doppler. That's one of the first things. How deep your box goes can, depending on the machine you have, can sometimes create a bit of the refresh rate could come down, so you might get a bit of a lag in your image. So on some machines, it's not as important as others. And then there's just your key settings. So there's your frequency, just like when on Grayscale, you have your frequency for your probe. The frequency of your Doppler tends to correlate with how deep of a structure you're looking at. So deeper structures, lower frequency, more superficial, higher frequency. But I do find that there is a machine-to-machine variation. Like some machines, that correlation holds very true, and on other machines, it doesn't. So I think you have to use, like when you're using different equipment, play with it and see what gives you the best image for what you're looking at. So frequency is certainly important, and depending on the machine and the probe, your range is always going to vary. Some probes and machines won't give you the full range that you might like.
So it sounds like we create a narrow, tall box. Is that how
yes.
you'd start?
Yep. I generally would start that way, and the rule that we like to go by is usually you want to see the box from the very top, because if there is other vascular structures above the area you're scanning, you can have artifacts and what we call mirroring that could give you a false Doppler signal in the area that you might be looking. So you always want to know, superficial to the area of your interest, is there any other vessels in that region that could be giving you a false positive Doppler signal?
Right, and it could give you some artifact. Potentially.
Exactly. Yeah, exactly. So aside from frequency, think about it like deeper structures, lower frequency. The next key thing, especially for slow flow and for synovitis, is your PRF, or your pulse repetition frequency. And your PRF is kind of like, there's the frequency at which you're sending your pulses, but then there's how many pulses there are per frequency. So, the way I could think of it is, if your frequency is set to like dup, 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 your PRF is kind of telling you how many pulses do you send per frequency. So is it da 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 versus da 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 da. So it's how it helps you, and it really gives you an idea. It's like how much are you looking at the area when you send a pulse. So if your PRF is too fast, right? How do I want to say it? It's like, if you have kids, right? Mm-hmm. You don't notice your kids growing because you're looking at them too much, right?
Okay.
You don't notice them because you're looking too often, right?
Time to a stranger, is slowed down.
Yeah.
Almost like infinitely slow. Almost like the day never passes.
Yeah. And for a stranger, like if I come over to your place once a year, I'm going to notice how much your son's grown. Like I'm going to notice, whoa, like you're so much bigger now, right? Mm-hmm. And PRF is the same idea. If you set the PRF too high, like you're looking too frequently, then you're not going to notice slow flow. You're just not going to see it because it's going to look like it's not there.
So you want to spend less time with your kids. That's what you're saying.
Yes, you'll notice the changes more,
okay.
Like how they don't like you if you don't see them. So you want to reduce your PRF. So the optimal PRF we say is between 500 to 1,000 kilohertz, and if you keep it in that range, what you're going to notice is you're going to detect slow flow better. Mm-hmm. So it's almost like you're looking and then you're looking away. You're telling the machine to look and then look away. And that kind of frequency range is really good for slow flow. And so what I would say is when you play with machines, now the one recent new problem I'm running into is some manufacturers now don't give the PRF as a kilohertz range.
Yeah.
They're giving it as a velocity range. Mm-hmm. So for PRF, the part that I find challenging with some of different manufacturers is most machines do tell it to be in a kilohertz range. So 500 to 1,000 is the nice range to kind of work in. But newer machines that I've seen, even with Canon, which is the main machine I'm using in my practice now, the PRF is given to you as a velocity scale. And even when I've talked to their head engineers, they can't give me a conversion table to tell me what PRF range falls into what velocity range. So they're working on that. So so this is a new problem I have not run into. Some machines give you the option to flip back and forth in terms of how you set your PRF, but I'm noticing that some aren't.
I think it's important to note that that PRF is a kilohertz frequency, whereas the fundamental frequency of our Doppler are different than that, right?
Yeah, and that's exactly the point. Like what I'm saying is, so on some of these machines now, they're not actually giving you the kilohertz range. As you adjust it, you just see the velocity change, but they're not actually telling you. You don't get to actually see the numbers, which I think is really baffling. But
is it in the same direction? So like a lower velocity is a lower kilohertz?
Yes, that's right. Yeah, exactly.
And then in some machines, the PRF is a 0 point something as well.
Yeah, and that one is if the scale's probably in megahertz.
Yeah, the scale's in megahertz to be correlating with the fundamental frequency of the transducer, which is in megahertz, right?
Exactly. Yeah, that's a very good point.
Okay, so tall, narrow box if you're doing a superficial imaging, and then you drop your PRF. Now, are you dropping your PRF until you get artifact and then increasing it again, or?
Yeah, so that brings us to a second point. So I feel like you read my mind. So I was going to talk about Doppler Gain. So what I would say is I usually on my machines, like I'm between a PRF of like usually between 600 to 750. That's usually where I find is a sweet spot. And I find that, if I look at an area, but I'm expecting to see something, I might drop the PRF right to 500 and I'll see if there's some background artifact that comes into place. But Doppler gain, think of it as, the volume, just like gain, like B mode gain, right? It's the volume knob, right? So you can turn up the gain. And in rheumatology, we like to make sure there's a little bit of background artifact where you see some like speckles of Doppler at the bottom of the box, just to know that your sensitivity is quite high. And so if I scan over an area and I have a little bit of background Doppler, then I see it really light up, I might make some finer adjustments and bring down the gain or go up on the PRF. But that's a good rule of thumb just in terms of increasing your sensitivity and avoiding a false negative scan.
So inherently you're going to have some blooming artifact here too, right?
Yeah, that's right.
Because your gain is going to be so high that it's just going to be, if you've got an artery or something, it's going to be flowing outside of that.
Yeah. So yeah, exactly. So for synovitis, blooming artifacts are fine. Like if you find it's too much and it's really taking over the image and giving a lot of false signal, yes, you might want to go up on your frequency. You might want to increase your PRF, turn down your gain. Those are the variables you're going to play with to optimize your image. Yeah.
Gotcha. So we were talking about we talked about the Doppler box. We were talking about PRF, and so we're dropping our PRF. We're sitting around 600, depending on the machine, for slow flow, and then we're increasing our gain to a point where we have some speckle artifact in the bottom of the image.
Yeah.
And if we're not seeing anything there, then we can rest assured that there's no flow to be found.
Yeah, and this brings up another important point when you scan for synovitis is the pressure you're actually putting on the area. How you're holding your probe and how much pressure you put the area, because if you if you actually compress the structures, you will make it look like there's no synovitis, and you can falsely reassure yourself that there's nothing there. And so a common phrase that we use is you need to float your transducer. And when you're looking at some of these areas, sometimes you have to use two hands depending on the area. Sometimes it's just a matter of how you position your hand. So I sometimes will, if I take a probe, and you have the benefit of seeing this, Peter, but if I'm holding a probe, I will put my fingers on either end of the probe so that...
Okay, so you're pinching the probe, and then you're using your thumb and your index finger or your middle finger to essentially lift the transducer off the skin.
Yeah, and that way I float it, and that way I don't compress the structures. Another technique that people will use is they'll put their finger, they'll use their pinky finger as a way to...
So you place the transducer in long axis along your fifth digit, and then balance the transducer in your hand there, keeping your fifth digit fully flat against the surface, and then using it to lift it off.
Yeah.
Certainly if you're crushing veins that are superficial, then you can definitely crush out some of that low flow, and just a little deep to that too.
Exactly. And when we review images, I usually try to look for a gel layer above the skin in certain areas, like if there isn't veins that I could use as a surrogate. If you know there's a gel layer that's available between the skin and the probe, then you know that certainly they weren't putting enough pressure to obliterate potential synovitis.
Right, so that's a reassuring finding.
Yeah. If you review other people's images, that can be really helpful.
Okay. Yeah.
And then really one of the things we haven't talked about, and maybe it should have been the first thing we talked about, but is the type of Doppler that you use. And initially, when we were using Doppler in synovitis, there's a lot of emphasis on using power Doppler versus color Doppler. And power Doppler really doesn't look at directional flow. It just looks at the amplitude of change. So it's more sensitive to slow flow. But what we're finding now is, as the technology with Dopplers improved overall with more modern machines, that's really not as important as it once used to be. So the initial thoughts used to be that power Doppler is better for slow flow compared to color Doppler, but now, as long as you have your settings dialed in, it doesn't seem to matter as much.
So really, the machines have a couple of different settings, but the ability of the Doppler to detect lower flow is not necessarily dependent on whether it's color or power now, as say 10 years ago.
That's right.
Right.
That's right.
With your because you're using several different machines right now.
Yeah.
And have you seen that play out, where you have one machine that's older and it has better sensitivity with power imaging, and the other newer one where it doesn't really matter?
Yeah. So the oldest machine I use is a MyLab Twice. I have something in the middle with the MyLab Alpha, and then there's the Canon i800 that I'm using. And there certainly is a spread between those machines. So the MyLab Twice, if I switch to Doppler with similar settings, like power Doppler compared to color Doppler, the power Doppler is way better.
Right.
It's like very clearly different. In my with my Alpha, I don't know if it's actually that much better. I think SAOT has generally had really good power Doppler, and so most of the time I am using power Doppler. But when I think back to some of the times I've compared it, I think I just stuck on power Doppler because I like the look better.
Yeah, I have similar kind of experience. I guess the question is when you have to do that, when you have to. If you get a new machine or you're using new machine for the first time, how do you choose the structure or the patient to make that comparison on?
Yeah, so this is a really good point. And somebody had come up with what we call the finger pulp test. Have you heard of this before?
No, no.
Okay, so this is a really great way. So essentially, you take a probe, okay, you put some gel on it, and then you rest your finger on the probe, like your index finger, okay?
Okay, so you flip the probe upside down, you put some gel on it, and then you rest your digit on it, okay?
Yeah, and you just want to make sure to keep a gel layer, so don't compress it. And that can be, you can sit there and play with your Doppler settings to look at how blood flow at the pulp of the finger, because it's a very vascular area at the tips of your fingers, and they're very superficial. So it's a really great way, if you want to sit there and really understand Doppler and how it impacts your imaging, to go through a lot of these things that we said. So you put your finger there, you put your Doppler on, you can dial in your settings, and then start playing with them. Turn up the gain, turn down the gain, turn up the PRF, and you'll see how the blood flow at the tip of the finger, which is a very vascular area, how the machine will recognize flow in those areas differently.
So the blood flow in the pulp of the finger is it should be present.
Yeah.
Yeah. Yeah. Okay, unless your finger is black and about to fall off,
or you're just like really pushing your finger down on the tip
you're
of the
crushing
probe.
it. Yeah.
Yeah.
Okay. And that's that's how you've been kind of looking at some of these initial settings.
Yeah, that's okay. Right. So it's a really good way to play with Doppler, because it gives you a good idea, like, because the flow at the tip of the finger is similar to the flow that you see through synovium,
right.
And that's why it's a really good circuit. I'm not sure who initially came up with this approach. I heard it once from Dr. Ralph Teal, who's a rheumatologist in Rochester and staff faculty at US Sonar, but it seems to hold up pretty well. So I have taken, when I picked up a new machine,
yeah,
I'll go with their manufacturer settings, or what their applications person suggests,
right.
And then I'll sit there and I'll put my finger and I'll sit there and start tweaking the settings until I find the setting that gives me a minimal amount of artifact with a little bit of speckle in the background, that gives me the nice clearest image with a Doppler, with and you play with that with your machine to see. And what I would suggest, if you're using more than one machine, or you're going to a new machine and you have a machine with prior settings, you could plug in the same variables and then compare them back and forth and see what you like. And it's nice because you can be doing that and you still have one hand free to tweak all your settings with. So it doesn't require two people to do.
I'm going to have to try that. The finger pulp thing. Yeah.
It gives you a good idea with synovitis, and you could sit there and play with different Doppler modes.
Right.
Different, again, like the thing that's becoming more available is every manufacturer on more modern machines is coming up with different forms of Doppler. So like my Canon machine has four forms of Doppler.
Right. Yeah. And your SAOT machine now has 3?
Yeah, the SAOT, there is, they also have X-Flow on that
right.
one. Yeah, so there's 3 there.
Yeah, my machines have 2 options. I think you could buy more,
yes.
Especially with some of the other larger brands like Philips and whatever. There's always more that they'll take from you.
Yeah, GE has it too. They all have their own proprietary software bundles that are play on Doppler. They are interesting. When I started playing, and I think every manufacturer will vary. So as an example, I still think that out of the machines I've played with, the SAOT has really great power Doppler. But when I play with a Canon, they have one called SMI, or Super Micro. It stands for something I can't recall from the top of my head, but it's called SMI. It's so sensitive. It goes to 5th order vessels. You see things in that. It doesn't look like big bloomy vessels. It actually shows you really fine, intricate vessels. And even if you sit there and play with the tip of your finger, the problem is nobody right now knows what that means. If I see this really faint flow, I'm always like, am I going to overcall stuff with that? They have another setting called ADF. Again, I don't recall what the acronym stands for, but it's a really nice way of seeing Doppler, and it actually gives you a lot of detail into the vessels that it goes into. So it's kind of fun to play with.
But you really don't know how to use that in clinical practice per se.
Yeah, sometimes what I do, so the way that that's changed my practice with playing with new technology like this is if I scan an area and I find that the power Doppler is not giving me a signal that the patient really has symptoms, or there is an effusion in an area, but I can't tell if it's synovitis versus effusion completely. Like I try compressing it and there's an element that's non-compressible. And I'm like, is this actually synovial thickening with no Doppler activity, or does it have Doppler activity but my machine can't pick it up? I'll switch over to ADF and then even SMI. The problem with using SMI on the Canon, for instance, is it has so much processing that goes into it that it creates like this time lag. So you can't just keep it on and scan. You start to feel like you're getting seasick. So I put that on, and sometimes if I pick up signal, I think that's like I'm seeing something that the machine would otherwise be limited. And when I was going through a trial period between the two machines, I put my SAOT next to that. And yeah, I found that sometimes where the SAOT might look like something that's grade 1 Doppler, where it's a little blip of Doppler activity, that one would actually elaborate it more and it would show more. So yeah.
So you're finding that at least in one individual where you had a little blip may have been inconsistent on power Doppler with the SAOT, you're wondering if it's artifact. It comes back every so often. And then you throw on this other machine with this other different Doppler processing, and you'd see some flow where that was more consistent in the same area.
Yeah.
So, I mean, that brings us to a point about processing power of these machines and that. So, even this Canon machine that you're talking about that's new, very expensive as well. Yeah. Has, probably an entire array of hardware just to process the Doppler itself, its own graphics card, its own processor for the Doppler, and still your frame rate is so slow in your machine that it's, you can't dynamically scan with it.
Yeah, I've literally, the way I've set up my machine, it's really funny because even their applications experts are like, we've never worked with a rheumatologist like this, but one of my foot pedals is literally just to turn on and off the SMI, because I'll turn on my Doppler and I'll go look through areas. And when I get interested, instead of having to fuss too much, I literally just put the power, I push on the pedal, pops up that SMI, and I'll pause for a moment to really interrogate certain areas if I'm suspicious. And then, I can pop it on and off and keep scanning and having a dynamic flow without getting too caught up in pushing buttons.
Yeah. I mean, that's definitely an element to scanning serial structures with low flow imaging is you do get slower frame rates. It does slow you down. You're often turning Doppler on and off, and that, I see that for sure. It's a little easier in the hand and foot where your structures are very close together and that, but still, even just like translating the transducer between an MCP can give you a lot of artifact. And I see that with the Sonosite machines. For sure, and you just kind of have to accept that. It's just, you sit there, you wait a few seconds for the artifact to dissipate.
Yeah,
do your assessment.
One of the settings that it can be helpful and hindering at the same time is your persistence setting. And different manufacturers sometimes call different things, but how long your Doppler signal is refreshing overall, like in terms of what it actually looks like on the image. So if you turn your persistence all the way up, it just kind of glows and stays there. And it, you could, even if you move the image somewhere else, that glow kind of stays there. Yeah. Whereas if it's really low, it flickers. Right.
Yeah. I mean, in some machines, the Grayscale Persistence is locked to the Doppler persistence as well. And so if you have your Grayscale Persistence high and you have these really swooshy images, you get the same with your Doppler imaging as well.
That's right.
So there's another thought that came to my mind is we haven't talked about wall filters.
Oh, okay, perfect. Yeah. So let me come back to wall filter for just one sec, because we're talking about great persistence and grayscale and B mode
Right.
and Doppler mode. But one other thing is some machines, when you turn on Doppler, is when you turn on Doppler, you can tell the machine what to prioritize more. Some machines give you that. Every manufacturer has a different name for it, but you tell it whether the machine should process the gray mode with more priority or the Doppler mode with more priority. Like GE can do that, the Canon can do that. My SAOTs don't do that. But there is this priority that you can give to them. And I find when I do hands and feet and other areas that I'm looking for synovitis, I usually tell the machine to prioritize the Doppler settings over the B mode. So just keep that in mind. Also, one thing that I didn't talk about, and this was just a point about the Doppler box.
Right.
Just remember one thing, and every machine, there are variances in machines. So if you go back to the basics, some machines, when you're in your grayscale, you where you set your focal point or the number of focal points you have, you're basically telling the machine where to focus on the imaging, right? And some machines have a scan, like you don't have focal points at all. And some machines, like the SAOT, where I tell the B mode to focus on, the Doppler mode does the same thing by default.
Yeah, they're linked.
They're linked.
They're linked.
Yeah,
basically link controls.
Yeah, and some machines, like my Canon, they're independent. So I could tell the B mode to focus somewhere and the Doppler to focus elsewhere. So just or you could just give it no focal point and it just scans the whole area. So I forgot to mention that, and I think that's important. Just remember where your focal point is in your box, and know what your machine, how that works. One thing you mentioned, so going to the idea of wall filters, and again, this is a very heterogeneous thing in machines. So some machines, the wall filter and your PRF are intimately linked and you can't uncouple them. So as you drop your PRF, the wall filters come down, and as you go up on your PRF, the wall filters come up, and the wall filter is just telling the machine what's background noise to cut out, right? So it kind of makes sense that if you come down on your PRF, you're willing to tolerate more background noise, versus if you go up on your PRF, you want less background noise because you're looking for fast flow, right? Now,
yeah, they are. I mentioned linked controls. They're definitely linked controls. These two, but there are some machines where you can delink them explicitly. Yes. I know that my Philips machine, one of them at least, you can unlink them and toggle them independently, but in general they're linked.
Yeah. So I think the SAOTs, the GEs, and even the Canon, for instance, that I'm playing with, they are you can unlink them and you can control them independently. It is a nice setting to be able to play with sometimes. Again, if you're scanning an area where you're not sure if you're missing out any signal, you can certainly toggle that. But usually I find once you've made your settings, your presets, it's not something you typically have to come back to and adjust.
Right, yeah. I guess we talked about probe pressure and that, but we haven't talked about probe positioning or angle.
Right. Yeah. No, that's a really good point. So typically, the key thing to remember is you want to try to be as create a situation where in Doppler in general where you're parallel to flow. But when you're looking at slow flow, it almost doesn't matter because you're looking at capillaries and you're looking at these structures that the flow is going in all sorts of directions, right? So the key part is with your B mode imaging, you want to get nice orthogonal views where you're perpendicular to the area that you're looking so that you have the best. So it comes back to some of the basics. When you go back to your B mode imaging, do you have a good image of the area of interest? Is it kind of central in your image? Is your focal points on point? Is your pressure low? And have you made the bony contours as crisp as you can, to know that you have a good baseline image before you turn on your Doppler to look at that area. So that's really important. But really, generally with Doppler, the signals you're going to pick up best is when the motion is parallel to the ultrasound beam, right? So those are the ones that you're going to see the best.
So if you're imaging like the radial artery, for instance, then you're going to want to try and be parallel to the flow itself, which means wagging the transducer to pick up the artery itself.
Exactly. And if you're in an area where you can't do that, like physically you can't actually position the probe the way you want, then using your Doppler angle in terms of your box, so how you shift your box to try to mirror as much of the parallel flow as possible, that you can adjust with that. So, usually by default it's set to 0 degrees. But just note that the more you adjust that Doppler box to pick up slow flow, you are introducing another variable now, which can give you false signals. So I usually try not to adjust the Doppler angle, and I keep my box a square. Yeah.
So grayscale perpendicular, Doppler parallel, high flow, you can adjust your Doppler box. Low flow, probably not really relevant. And you can be getting errors in terms of false positives, or background noise or something.
And one thing I would suggest is if you do the finger pulp test that we talked about, play with all of these variables, including your box size. So look, if you find an area where you get really good signal, make the box size smaller, and then you'll see how much it blooms in that area versus if you just cover the whole finger width. Play with your focal points, and you'll see if you set it at the bone versus in the middle, and it'll really take a lot of these things that seem somewhat abstract right now and make it very tangible.
So then how do you set up your Doppler box looking for synovitis in the hip?
Oh yeah, so the hip's really hard. So looking at superficial structures is much, much easier. Deeper structures. So if we were going to talk about the hip, I can tell you that there's numerous times I've seen, when I set up my Doppler for the hip, usually it's if I'm trying to look for those lateral cutaneous nerves of the thigh, like that, for things to avoid if you're sticking a needle in the hip. But to actually see synovitis in the hip, I don't even think I've ever been able to pick it up, like legitimately.
Oh, okay. So yeah, because in children, they're thin.
Yes. Oh, for sure. Yeah.
And so you can basically, cover the most of the structures that you need to see, because the imaging is going to be in the near field anyway. And you can use a linear transducer often for these really small children.
Yeah.
But when we're looking at adults and hip synovitis, we're using a curvilinear transducer. Usually we're limited by processing power to have the Doppler box over we're 4 centimeters or more.
Yeah, sometimes deeper. 6 and bigger people. Yeah.
Yeah, exactly. And so you're saying that we're still using power. We are creating a Doppler box as small as possible in the far field, right? And then using the same variables of adjusting the PRF to as low as we can, and then increasing the gain until you get artifact. And again, trying to keep the pressure off, but knowing that the pressure transmission is going to be a much different mechanically for that kind of a deep structure, right? Yeah. I've seen it a couple of times in a hip. Really bad osteoarthritis can do it. I had and then I had a lady who presented with a super irritable hip. You log rolled her hip, and she was screaming, and she had an effusion and thickened capsular ligamentous complex and synovium. It was all indistinguishable, and it lit up like a Christmas tree. With imaging. She turned out to have small cell lung cancer.
Wow.
And it was the first presentation of that systemic event. Yeah, I know.
Was it a metastatic lesion, or was it a perineoplastic process, you think?
It was a perineoplastic process. Yeah.
Wow.
Yeah.
Wow.
Very weird.
Yeah. I mean, I could tell you.
And it was
I saw this woman.
I imaged her. Oh, sorry. Is there a lag in our...
I got a signal saying we had an unstable connection.
Oh, yeah. I've had it come and go. It's what it is. The GP really helped me with that case, because I got the... I ordered some imaging of her hip, and her hip looked pristine. Like she was in her 70s and previously, had a little bit of knee pain. But when we imaged her hips, like it was normal. And from bony imaging, and then the GP just like pan CT'd her.
Wow.
It's just like, and her lungs, she ended up having lung cancer.
Wow.
So yeah, the GP we just saw a normal X-ray, and I told him that there was a hip effusion and synovitis, and then he just pulled the trigger and scanned her, did all blood work and that kind of stuff. Anyway, he's retired now, so it's too bad. So,
wow, yeah, he actually took lead in the case. That's great.
Oh yeah.
I mean, I can say the most inflamed hip I ever saw, like it had a cell count of like 99,000, right? But what was interesting, and this was using a portable alpha, so it's certainly not like, there's some limitations with the equipment. But on that, I remember when I had tried to look at the hip, I couldn't detect any synovitis on the scan. I was still able to aspirate the hip under guidance. Yep. And that's how we got that cell count back. But I still look, and I think I've only had my new Canon machine since January, so I just haven't come across enough. I've seen maybe like a dozen hips, but nothing that's come back like that inflamed. So I still look with the Doppler. I still try to see, but it doesn't always pan out.
Yeah. Well, I think that we should probably end around here. We've covered all kind of like the intro to Doppler, really.
Yeah.
I'd like to do another session talking about pathologic imaging and that. Hopefully we can get it set up so that we could like do like a Zoom or some kind of video conference and then throw up some images. Well, guys, that's it. Thanks for listening. I will post this on my YouTube channel, and if you have any questions or comments, leave something down below.